Greetings to everyone. I wish all of us are safe and in good health. Today's presentation is held in conjunction with the celebration of World Antimicrobial Awareness Week 2021. We would like to highlight in this presentation specifically about pediatric dosing from National Antimicrobial Guideline 2019. As an introduction, I would like to share about World Antimicrobial Awareness Week. It was first endorsed at the 68th World Health Assembly in May 2015, with the objective to increase awareness of antimicrobial resistance. It is a responsibility for us, as healthcare medical practitioners, to apply best practice in antimicrobial selection and treatment to avoid further emergence and spread of drug-resistant infections. Our main highlight in this presentation is about our National Antimicrobial Guideline, which was proudly launched in 2019. As mentioned by our Honorable Director General of Health, it is one of the essential documents that can benefit all MOH employees. This guideline is easily available and can be searched through and downloaded from any search platform. The objective of this study is to assess knowledge of pharmacists and medical practitioners on pediatric dose of antimicrobials used in common infectious disease based on NAG 2019. We would like all attendees to be familiar with National Antimicrobial Guideline, and to use this as a main reference for antimicrobial dosing guide. These are the common references used to look for pediatric drug doses, namely NAG, Pediatric Protocol, BNF, Frank-Shan, MIMS, Micromedics, Uptodit, Lexicomp and Medscape. For every reference, different doses are actually suggested for the same medicine. I would like to present a case scenario of a doctor who wanted to start syrup amoxicillin to a patient with pneumonia. The doctor referred to Frank-Shan for the amoxicillin dose and suggested 25 mg per kg TDS, then prescribed to the patient. Once the prescription arrived to pharmacy, the pharmacist referred to National Antimicrobial Guideline to double confirm the dose. It was found that NAG that the recommended dose for amoxicillin is 80 to 90 mg per kg per day in 2 divided doses for pneumonia patient. Intervention to the prescription is done by contacting the doctor. Intervention actually increases time for drug delivery to the patient, which may delay treatment time. Using the same reference might ease both sides, the doctor and the pharmacist, in prescribing and supplying the medicines. Why do we suggest for all antimicrobial dosing to refer to NAG? Because NAG is formulated by a large core team stakeholders. It has been formulated with some guiding principles that our recommendation will not just only be evidence-based, but also that it has to be pertinent to the local situation and realities. As a general guide, NAG 2019 consists of 2 main sections, which are adult and pediatric. Our main focus for this presentation is the pediatric section. We're going to discuss on some common infection in pediatric patients as highlighted. How to read NAG. The table consists of 3 columns. First column is where you look for what infection condition you are treating. Then, refer to the preferred or alternative treatment suggested in second column. Column 3 explains any additional information related. Now, we will be more focused on the choice of antibiotics, dose, frequency as well as duration for above common infectious diseases among pediatric population. One common condition that is normally found in children is meningitis. Note that there are slightly different susceptible organisms in different age groups of patients. Intravenous cefotaxime or ceftriaxone together with benzylpenicillin, with the dose recommended as such, is used empirically in management of meningitis. It is in line with our current practice in the ward, which is IV cefotaxime 50 mg per kg QID, IV ceftriaxone 50 mg per kg BD, IV benzylpenicillin 100,000 units per kg QID. According to NAG, for patients aged below 3 months, cefotaxime is the preferred antibiotic due to less drug-drug interaction. The preferred antibiotic used for pre-operation such as cardiac surgery, thoracic surgery, and abdominal surgery in children is IV cefazolin 30 mg per kg with recommended redosing interval from initiation of the preoperative dose every 4 hours. Pertussis, also known as whooping cough, is one of the commonly seen respiratory diseases in pediatrics. The drug of choice for pertussis and treatment is a macrolide such as an azithromycin or erythromycin. Patients with different groups of ages recommend different macrolides. For younger age patients less than 1 month old, azithromycin is the preferred agent compared to erythromycin. However, erythromycin is still considered as an alternative if azithromycin is not available. Undoubtedly, the use of azithromycin or erythromycin is associated with infantile hypertrophic pyloric stenosis in very young infants, especially in an infant less than 6 weeks. Despite how azithromycin remains the drug of choice in very young infants because the risk of developing severe disease outweighs the potential risk. Dysentery is an important cause of morbidity and mortality associated with diarrhea. About 15% of all diarrheal episodes in children under 5 years are dysenteric, but these cause up to 25% of all diarrheal deaths. Despite that, most of the mild and uncomplicated dysentery will resolve spontaneously without antibiotics. For patients who are diagnosed with mild dysentery and require hospitalization, oral ampicillin 100 mg per kg per day in 4 divided doses is recommended. However, oral ampicillin is not available in our hospital, therefore IV ampicillin is commonly prescribed indeed. In addition to that, IV ceftriaxone is used in severe dysentery for hospitalized and immunocompromised patients. Fluoroquinolones are not routinely used as first-line therapy in pediatric patients, and are only reserved for isolates where there is no other antibiotic option available due to its potentially irreversible adverse effects. These serious adverse effects as listed generally outweighs the benefit. Pediatric is susceptible to otorhinolaryngology infections such as tonsilopharyngitis and rhinosinusitis as well as acute otitis media. Oral phenoxymethylpenicillin, which is also known as penicillin V with a dose of 25 to 50 mg per kg in 4 divided doses, or oral amoxicillin 50 mg per kg per day in 3 divided doses is suggested in tonsilopharyngitis. From the table, we can note that the same drug, amoxicillin but different doses and frequencies were recommended for different diagnoses. Therefore, it is important for the medical practitioners to prescribe drugs and for the pharmacists to recommend or supply the drug based on the patient's diagnosis. Besides, oral augmentin 45 mg per kg per day in 2 divided doses is also recommended as a second-line antibiotic in rhinosinusitis. In the case of failure in the use of augmentin, can alternate with oral clindamycin or oral cefuroxime with the regime as shown. Rhinosinusitis and acute otitis media often require a higher dose of amoxicillin 90 mg per kg per day in 2 divided doses orally as compared to tonsilopharyngitis. Consider the use of oral augmentin for clinical failure in acute otitis media, or history of using amoxicillin in the last 30 days and has concurrent purulent conjunctivitis. Treatment for acute otitis media and acute otitis externa are different. Generally, an oral antibiotic is recommended for otitis media, whereas topical antibiotic, such as gentamicin 0.3% airdrop with a dose of 3 to 4 drops 3 times is recommended for otitis externa. Next, we will be talking about common respiratory infections in children. The preferred antibiotic for outpatients who are diagnosed with community-acquired pneumonia is amoxicillin, with a high dose of 80 to 90 mg per kg per day in 2 divided doses. However, due to compliance issues in children, a discussion has been made among the healthcare professionals to use the dose of 30 mg per kg 3 times daily. Besides, for community-acquired pneumonia caused by a viral infection, consider adding on oseltamivir as stated dose. For inpatient management of bronchopneumonia in a child who is fully immunized, IV benzylpenicillin is always the first choice of antibiotics, with the dose recommended as such. For the second-line antibiotic or for partially treated pneumonia, consider using IV cefuroxime 100 to 150 mg per kg per day in 3 divided doses or IV augmentin 30 mg per kg TDS. For a child who is not fully immunized or in life-threatening condition, NAG suggests using IV cefotaxime or IV ceftriaxone as a first-line antibiotic instead of IV benzylpenicillin. Otherwise, escalation of antibiotics can be made if the patient has no improvement with 5 to 7 days of antibiotics. Antibiotic is required to treat leptospirosis in children. Choice of the antibiotic is based on the severity of the disease. Children with a mild infection can be treated with oral amoxicillin if they are younger than 8 years. Oral doxycycline is used for children 8 years and older. This is because tetracyclines can cause staining of the teeth in young children. Some patients with leptospirosis become very ill and should be hospitalized to receive antibiotics intravenously, such as IV benzoyl penicillin, IV ceftriaxone, or IV cefotaxime with duration of 7 days. Urinary tract infection is one of the most common pediatric infections. It distresses the child, concerns the parents, and may cause permanent kidney damage. It can be treated effectively with antibiotics. For a child younger than 2 months old, NAG suggests using intravenous ampicillin in combination with gentamicin. Frequency for both antibiotics is determined by the day of life in patient. Intravenous cefuroxime with or without gentamicin is used in children more than 2 months old. Trimethoprim sulfamethoxazole, Bactrim, or nitrofurantoin are the usual choices antibiotics for UTI prophylaxis in children. The doses are stated as such. However, according to NAG, antibiotic prophylaxis should not be routinely used in children with first-time UTI. As a conclusion, we humbly promote everyone follow the latest antimicrobial guideline and to keep a soft copy of this NAG in your respective phone to ease access whenever required. With that, I thank all of you for your precious time and attention, and I hope that this presentation will benefit everyone and meet its purpose. Thank you again and have a nice day ahead.